Welcome back to the Physical Therapy San Pedro podcast. This is episode 67, and today we are discussing all things shoulder dislocation. I am your host, Dr. Janae Brown, and I am a sports physical therapist and owner of Physical Therapy San Pedro, and I'm joined by my wonderful team of physical therapists. To my left is
Dr. Silverton.
And to my right,
Dr. Bay.
So thanks for coming back with me, guys. I'm excited to have my team back in here for this podcast. Today we're talking shoulder dislocations. We're going to talk about the shoulder dislocation diagnosis and, the injury in itself and the rehab process. So, Dr. Silverton wrote this blog for us and kind of helped prep for going through this whole diagnosis. So, Dr. Silverton, want to share with us why you chose shoulder dislocation?
It's one of the interesting diagnoses that we come across in physical therapy, that we see a lot of tendon strains, muscle strains. We see a lot of normal things like that. But when a joint no longer is connected to the other side, that doesn't happen all that often. And the shoulders is one of the most common ones. So we haven't really covered any of that. We've covered other diagnoses throughout the rest of the body. But a dislocation is a new one for us here.
Yeah, absolutely. We haven't covered diagnoses on dislocation yet. I don't think we did patellar or when we did patellar. So this is a good one, and we see it. It's one of the common ones we see in the clinic, which is like what we try to discuss with you guys, things that we see often and things that you guys might be experiencing. So thanks for writing this, Dr. Silverton. Why don't we start by diving in with what a shoulder dislocation is for our audience who may not know?
So general anatomy, our bones are held together with ligaments. So on this model right here, we have if we were to put it right in front of my shoulder like this is the arm bone coming down this way to my elbow. This shoulder blade is on the back side, on the other side of my rib cage. This is the collarbone on the front side here. So when we're talking about shoulder dislocations, we're talking specifically where the arm bone is attached to the shoulder blade there. A dislocation is if this is the surface of the shoulder blade and you have a little ball on this other side of it, that's really about how shallow the joint is. And it's all strapped together with ligaments and then reinforced with our rotator cuff coming around the side of it. So when you dislocate it, you can see that it doesn't have a very deep structure for that ball to be held in place by the shoulder blade. So when it's more shallow that way, it's easy for it to slip off. The positive side of having a really mobile joint like that is that we can reach all sorts of directions and do all sorts of great things with it, like throwing things. But it does make it more unstable. So when it dislocates, the ligaments get stretched out, and sometimes it'll stay that way, or sometimes it'll automatically pop back in, if some of you may have experienced.
Yeah. Tell us what the 3 different types of dislocations are.
It's just the different directions that they can go. The most common one is when it dislocates anteriorly. If you dislocate it posteriorly, so sometimes you get that if you fell on an outstretched hand, it kind of pushes the arm back behind you. You can also dislocate inferiorly as well. And there's different ways of relocating those depending upon what the doctor sees in the ER.
Yeah, absolutely. So you did talk about how the shoulder has this shallow, the glenoid has a shallow surface, which makes the shoulder very vulnerable. Why is it important what are some things that in the shoulder that help to support and stabilize that joint, being that it's so shallow and easy to dislocate?
If you look at only the bony structures of it, it's a pretty flat surface on the shoulder blade with a pretty round surface of the glenohumeral head. To make the surface of the shoulder blade a little bit deeper, we have the labrum. It acts as a little bit of a chalk block underneath. If you take a cross section, it's like a little triangular chalk block there. This thing can't slip down quite as easily. We have ligaments strapped all around it. So if those get, if you're not doing anything, your arm just doesn't fall out of place. If you're doing something with it, you're trying to move, then the rotator cuff comes in and helps pull the head of the humerus into the shoulder blade, so that way it compresses, and that way it's less likely to come out.
Yeah, absolutely. Great. Yeah. So we have our labrum, our ligaments that are kind of holding bone to bone, and then our muscles that are holding muscle to bone that help stabilize. And that is, those are keys for us to keep that shoulder stable. And it's really what we spend a lot of time in rehab working on when you dislocate your shoulder. So And it's also, we also noticed too that like the importance of all that stuff working together is really important as well in the shoulder because of the vulnerability of it. We need to make sure things are working together well so the shoulder moves well. So
a breakdown in any part of those can lead to someone being more likely to experience a shoulder dislocation. Going so far as not even just the muscles of the rotator cuff, you can talk about the muscles of the shoulder blade or even the abdominal muscles. Say someone's a pitcher and they're trying to throw really hard. If they're not rotating from the hips and the trunk as much and they're trying to overclock their shoulder, that can lead to rotator cuff tears and eventually the little bit more instability on the front of the shoulder, and then they can dislocate that way as well.
Yeah, it's true. So we got to make sure you're in a good position with that shoulder, especially if you're doing any sort of overhead sport. It's really important that your shoulder is strong and stable. Dr. Bay, why don't you take us into mechanism of injury? How does this happen? How do people dislocate their shoulder?
Well, there's a couple common ways. Dr. S mentioned one already, which is when your arm is outstretched, falling onto it, the force of the trauma pushing through your arm can dislocate it from the socket. Also, direct impact and trauma, think contact sports or car accidents. Another common one is when we're in the overhead or throwing position. This kind of 90-90 is a very compromised angle for the front of our shoulder. So it's very common when throwing to get an anterior dislocation. But a key takeaway is that if you have an injury and your arm is forced back and you feel a pop, it was likely a dislocation.
Yeah, so you don't want that.
No, please don't. Don't do it.
What are some signs and symptoms that we see in people if someone would say, like, I kind of have shoulder pain. It sounds like I heard a pop when I did something, but I'm not really sure if I actually dislocated my shoulder. What are some things that they should look out for?
Definitely, like you mentioned, the pop followed by immediate pain, a lack of ability to move or range your arm, and then the classic sign is that it looks sunken, so that your shoulder head is sitting lower than it naturally would sit, would indicate that it's not aligned properly in the socket. Some things that people also might experience is the fact that they don't want to move their arm. They're very guarded. Swelling could collect in the area because there's a lot of other structures. You might experience numbness or tingling because of the nerves that are in that armpit region, or weakness because those nerves, again, can't feed the muscles.
Yeah, absolutely. Have either one of you ever had a patient that contacted you because their shoulder dislocated, or they came into you first before it had been reduced, which I'm going to talk about next? Mm-mm. No. Have you had anybody that's come to you? No, so it always has come to you kind of already set back in the socket.
Grateful for that.
Yeah. I've had a couple patients that are repeat dislocators, so they've come to me, and most of the time they know what to do. But yeah, so I'm going to talk about what to do. So the most important thing that you need to do if your shoulder gets dislocated is we need to put that head back in the socket. So to put that sucker back in, right? So we got to get your shoulder reset, and we call that a reduction. So that reduction can happen spontaneously. It could be something that just natural movement. Sometimes the natural movements that we do would, put the head of the humerus back in the socket. But sometimes it doesn't. And when it doesn't, it's painful. And you need to go to typically the ER is the place where they see a lot of these shoulder dislocations. And a physician there will reset it, and we call it a reduction, put it back in place through a manual technique. And it's pretty quick and fast, and reset it back in. But that we call a reduction. If you have a spontaneous reduction where, just kind of naturally goes back in, we still, we would recommend that you would get imaging either way, whether you had to see the physician and get it reduced or you spontaneously reduced on your own. And the reason for that is sometimes there's other complications that happen from a shoulder dislocation that can be a secondary problem. So imaging will sometimes give us a little bit more information about what's going on inside that shoulder. So some of the things that possibly could be going on as a secondary injury with that shoulder dislocation are a Bankart lesion, which is a labral tear, so a tear of the glenoid labrum that Dr. Silverton discussed earlier, which is the cartilage inside the surface of the shoulder on the inside of the scapula. Also a bony Bankart lesion, which is it's a double whammo. So you have a tear of that labrum, and then you also have a fracture of the bone. And then the third thing could be is a Hill-Sachs deformity, which is a compression fracture of the humeral head. So this is the humeral head right here. So that is something to be concerned about as well. And all those might need some surgical intervention. So in addition, there is 40% of all shoulder dislocations involve the axillary nerve. The axillary nerve is sort of the powerhouse that brings all of the power supply and communication to the shoulder. So if that's involved, that could be problematic if you don't have the motor supply there. And then 25% involve fractures, which we talked about above. And we also see that the risk of recurrent dislocation can happen, and that's a little bit higher in younger athletes. So that recurrent dislocations can happen as well. So those are some of the things that we tend to see as secondary problems. So again, recommend imaging if you have a dislocation, just to make sure that everything's nice, set, that shoulders back in the socket, everything's okay, and you can move on with your life. So not fully move on, because you probably need some help, but move on. So Dr. Bay, why don't you talk to us about what one would expect if they dislocated their shoulder?
Yeah, so there's a couple factors that influence the prognosis of your shoulder dislocations recovery. The first one being age. When we're a little bit more advanced in age, our tissues might not be as elastic or able to rebound. They might remain a little more outstretched. Our activity level always plays a role. As Dr. S. discussed with our anatomy, we're very reliant on our muscles for some of the stability of the shoulder. So typically we see people that come in with a better base of strength have a better outcome. The severity, Dr. Brown told us about the different lesions and fractures that can happen, and that complicates the recovery. And then also if this is the first time you've dislocated, or if you're a multiple dislocator, the more times you dislocate, that might complicate your recovery process because you have a higher level of instability. So the timeline you're typically looking at is 3 to 4 months after your dislocation to stabilize and recover your range of motion and strength for daily activities. And then your goals need to be assessed based on a sport-specific level. And then your therapist can guide you from there to achieve each one of your goals.
Awesome, yeah. So what would be some of the treatment options for someone who had a shoulder dislocation? What are the different things that a person who dislocated their shoulder might have to help them?
Yeah, so first, early on, if you are not a surgical candidate, you would be immobilized in a sling. You would be encouraged to keep your shoulder moving, and then you'd be going to physical therapy to see us so you can start to restabilize everything. And then the other option is if surgery is an option, that you would have the surgery, and that would be because you've dislocated so many times that now you need surgical help to make your shoulder stable, or because one of those lesions happened that Dr. Brown discussed and you need a surgical repair of the labrum, for example.
Perfect. So surgery or no surgery, you're likely going to end up in our office, which is why we're talking about this, because we see it happen on both ends of that. We see patients that have surgery and we have to take them through the rehab process that way, and those that haven't. Have you guys noticed that you see more surgical versus non-surgical approaches to this particular injury? What do you guys see? Have you seen a lot of surgery or in your guys' opinion, surgery, non-surgery?
Both sides.
Both sides.
Yeah. I don't know, probably maybe 50-50, but maybe more towards the non-surgical side.
Yeah.
Yeah, probably more non-surgical, but I thought it was interesting. In the past, I saw a set of twins that both had to have the same surgery.
Oh, wow. That's really interesting. I've seen surgery done in younger athletes. So I think like high schoolers, if they're dislocating and repeating dislocate, I've seen those have a lot of surgical intervention. But I think adults, physicians are trying to approach that with a non-surgical approach if there's not anything too complicated that is occurring. So that's kind of what I've seen mostly in my practice. Yeah. Okay, well, let's go into the rehab process, which kind of starts the same, a little bit of the same. I think we can talk a little bit about the difference maybe between surgical and non-surgical, but starts kind of the same. Dr. S is going to take us through the phases of rehab and some of the things we do in each phase. So Dr. S, start with phase 1 for us. What happens in the first phase, and give us sort of what the sort of goals are in that phase and the timeline in that phase for us.
The main aspect of phase 1 is just protect the joint, so that way you're not going to dislocate it again, because things can be loose. So you don't want to be pushing the patient towards any position where it feels like the joint's going to dislocate again. So over the first week or two, they'll be in the sling so that the way they can protect it. You're going to try to do any sort of thing to reduce pain and inflammation. So if the doctor gives any sort of pain medications, or if there are any sort of techniques that we can do in the office, whether manual therapy or even with any other modalities, to help with the pain. But sometimes just moving the joint gently is what helps out with the pain the most, just because you're stuck in a sling, you just had a big injury, and now it's just sitting in one spot. It just gets really achy. So just gentle passive range of motion. All these phases are broken down into passive range of motion, active assisted range of motion, and active range of motion.
Yeah. Phase 2, did you go through that?
Phase 2 will be restoring mobility. So after between 2 to 6 weeks, you're just gradually increasing range of motion. You're also gradually increasing the amount of muscle usage you're using. You may not have them fully lifting the weight of their arm right off the bat, but you're working towards their ability to use their muscles to lift up the weight of their arm. And you're just avoiding any sort of positions that, again, still trying to avoid anything that may cause a redislocation of the shoulder.
Okay. What's phase 3 look like?
Phase 3 is when they're much more stable. So about 6 to 12 weeks out, pain should have gone down. Range of motion should be almost all the way there, if not already back to full range of motion. Gradually increasing on how much you use the muscles. So the patient will be able to, at that point, use their arm with most day-to-day reaching sorts of things, but lifting heavier things, pushing, pulling heavier things may still be aggravating just because stuff got stretched out from the dislocation. So training them to gradually be okay with that, get the tissues to be able to create that tension again and get that compression back in the joint, so that way they're more okay with day-to-day activities and getting back towards normal.
Okay. And phase 4?
Phase 4 is going to be for the advanced strength, and also getting back to full activity. So without even really thinking about it while you're doing all the things, higher level sorts of things, swinging a hammer, throwing a baseball, doing fast motions with the arm. If you're having to crawl on your arms because you're a plumber and you got to go underneath someone's house. Or if you're a quarterback and you got sacked while you're trying to throw a ball and you dislocate your shoulder, well, this is the phase where we're going back to throwing footballs. And then, also full contact sports happens during that time too, once we feel confident that they're not going to redislocate, that they've gone through the steps of rehabilitating all the tissues that were injured, and they're back to practice and getting back into the swing of things for whatever their sport of choice is.
Yeah. And so we're setting up fun things for you guys to do in clinic to mimic return to sport criteria. What are some things that are essential and important before we turn any athlete back to sport as it relates to a shoulder dislocation?
Before they go back to full sport, symmetry in their motion, their strength from side to side. For this, with our clinic, we have the valve dynamometers, the dynamo, and to test for actual, down to the newtons of force, we can figure out how strong you are on one side compared to the other. So that maybe we make sure that things are more or less back to normal. No pain with functional movement. Good neuromuscular control. They're not trying to shrug in order to get their arm up. They're not doing any sort of weird sort of motions as they're going through, say, a bench press or a pull-up or anything like that. And that they can tolerate a sport-specific load. And then we just gradually bring them up to it. So if it was a baseball player, put them on a pitching program where they're getting a lot of repetitions of it that doesn't bother the shoulder, at gradually increasing distances. So that way they have to throw a little bit harder and harder, and they get that gradual exposure to the tissues. So that way they get tougher and tougher again.
Yeah, it's good stuff. So all the fun things in the return to sport phases, because we got to figure out what sport you're doing and what you got to get back to and create some challenges here. So Dr. S is good at that. He's done some fun stuff with some of our athletes here in the clinic. We all have in a different way. It's fun setting up things to sort of challenge you guys back to your sport. So, okay, so key points and takeaways from that that are important in the rehab process are you can't skip phases. So one phase leads to the next phase. I think we would probably see that people skip the last phases of rehab the most. Rehab is a long process, but you got to stick with it. And if you really want to get back to your sport or get back to a shoulder that is healthy and feeling good and is there for you in your future, you got to go through all these phases and get your shoulder strong and stable. Feeling better doesn't mean that you're ready to go back. So we can feel good, can be pain-free. You can feel like you can do things, but if you can't do the things that you need to do, then you're not ready. And so you put yourself at risk for re-injury. So you got to be able to work all the steps, do all the things that you would need to do for your daily life, no matter what your work, school, what your sport is, the things that you need to do every day, you got to be able to do. So we got to work through the rehab process and see what you can do. And then strength and control equals stability. So we need to get you strong. We need to get you controlled so we can get you stable. That makes your shoulder stable in the socket and reduces your risk of re-injury. So those are the key takeaways that are really important. And, physical therapy matters. Like it really matters in this particular injury. It's just key to seeing you through. We got to prevent re-injury. We got to restore stability. You need some structured progression. And so without physical therapy, you won't have anybody to guide you through that process. And you could, do a lot of missteps and a lot of regressions and maybe not get where you need to go. So I don't think you really have an option with this injury. I don't know if you guys, but like if you have a shoulder dislocation, it's very hard to move in your life and move forward in your life without getting some physical therapy help with this particular injury. So it's just hard to move forward with an unstable shoulder. So do you guys, in terms of shoulder dislocations, do you guys feel like this is a hard injury to rehab? Is this something that is sort of pretty straightforward? If you work the steps, your athletes work the steps, you pretty much get to the end goal? Or have you had any patients or do you see frequently patients that struggle to get back to the things they want to do with this particular injury? Your thoughts?
The hardest ones are typically patients that chronically dislocate again and again, just because, like, if you dislocate it once, sure, you stretch it out, it goes back into place, and things aren't so bad. But if they have things that are leading to the shoulder to dislocate over and over again, then there's more than those. Something's quite loose in there, and that takes a bit more work for us to guide them through, and it's a little bit more frustrating on the patient's part too.
Yeah, true.
Yeah, I've been pretty successful, but those that require the surgery to stabilize is a little more tricky.
Yeah. My patients that have had to have surgery, which are usually younger athletes, I feel like, and most of them we've tried rehab first. So I think the key is like, if you're a dislocator, you dislocate, and there is no severe lesion, there's no labral tear. Even if there is a labral tear, if there's no bony fracture or something that can't be rehabbed, rehab is a good place to start. But I've had patients that have been unsuccessful in rehab because they just feel so unstable. We do everything to try to get them stable, and they're still not there, and they end up having surgery. And what I've seen with those patients is that the shoulder never feels 100% normal. Like, either there's some place of instability or some place of, just pain or maybe a little bit of impingement somewhere, but it's hard to get it even post-surgical, like just feeling the way it should. And I think that's the big challenge that I've seen. So yeah, do you guys have any other thoughts about shoulder dislocations, or you have any other thoughts about anything you want to share with our listeners or followers about this particular injury that you feel like is important for them to know?
Going into the some people that do dislocate, we do have to go a little bit more sleuthing to figure out why they dislocated. So, say with throwers, maybe they don't have strong hip and trunk mechanics when they're throwing. So, like I said before, they're overclocking their shoulder. They're relying out too much on shoulder strength to chuck a ball real far, and they end up with shoulder issues. So, whether it's a dislocation or if it came from, or if it leads to a rotator cuff strain or a labral tear or anything like that, a lot of it comes down to some mechanics that we might be able to figure out where it's like, yeah, I can see how that could have led to that in the first place. Obviously, the counter example would be if they just fell. Then those are much easier because, well, don't fall again. Just let's put the shoulder back to normal. And yeah, just be careful when you fall next time.
I won't do that.
Yeah, it's the ones that have like the more of the overtraining or like a injury that came from just a repetitive activity like throwing or that. Yeah, you're going. Okay.
Overstressing the wrong tissues repeatedly.
Yeah. Yeah, exactly. And the goal is that, coaches and, strength and conditioning coaches and, people working with the athletes catch that early on, but it doesn't always happen, especially in the high school athlete where, their bodies are changing and they're growing and everything might not be, symmetrical. Those are the ones that are tougher. And that's probably the ones we see that education needed and where we're spending some time, not just on the shoulder, but we're spending time on other areas of the body that need to be addressed as well. Yeah. Yeah. It's good stuff. Well, we hope this episode helped you learn a little bit more about shoulder dislocations and what the rehab process really looks like. So if this is your first time tuning into the Physical Therapy San Pedro podcast, we're going into shoulder right now, and this is the first one. So we have 2 more shoulder diagnoses that we're going to discuss. So stay tuned for the shoulder stuff. But we have 66 other episodes that you can go and watch on YouTube. You can listen to our podcast at anywhere you listen: Apple, Spotify, Amazon. So go check out those episodes. Like, share. Subscribe if you enjoyed this and if this was a topic or information that you feel like is helpful. We want to keep bringing you guys content that you guys are enjoying and learning from. So please tune in and share with your friends. We also have some cool athlete interviews and some interviews with different practitioners about different things that are related to fitness and health and wellness. So check that out. If you're dealing with a shoulder injury and you need some help, we see our patients in our clinic here at Physical Therapy San Pedro in San Pedro, or we do telehealth and see kind of clients all across the world. So if you need some help and you want us to help you, you can book a session on our website at physicaltherapysanpedro.com and we can help you right away. And if you are interested in finding out what we do in our clinic or just tuning in to our day-to-day here, you can follow us on our social media channels at Physical Therapy San Pedro. And I think that's all I have for you guys. Till next time, we'll see you next. Bye.